PGR, prosthesis for large resections, was created in 1981 for replacing the proximal epiphyses of femurs affected by primary or secondary tumors, comminuted fractures unsuitable for osteosynthesis, and severe destruction caused by septic and aseptic failures of first, generally cemented, implants. Due to its versatility, which derives both from its modular design, the first ever for this kind of prosthesis, and from its cementation, its use was quickly extended to the upper and middle thirds of diaphyses with the same indications. The TALV 64 alloy provides lightweight, high resistance to fatigue and elasticity, necessary to withstand the stresses applied by often young patients and the fact that these implants can be very long. The modular system, which uses just a few components, was designed to meet the variety of requirements listed. It is made up of a neck, a stem, and a spacer. The neck, or epiphyseal component, comes in only one size, with 12-14 or 14-16 taper, 140-degree opening, fin with holes and tunnel for rethreading tendons, and double screw thread, internal and external, for the stem and spacer. The stem is straight, threaded at the base for the neck and rounded at the end. 3 long grooves run along it lengthways, which give it a 3-lobed cross-section. It comes in 3 diameters, 12, 14 and 16 millimeters, and in 3 lengths, 240, 290 and 340 millimeters, making a total of 7 combinations. The spacer is cylindrical, with one end threaded internally for the neck and the other externally for a ring. It has a single diameter of 27 millimeters and 6 lengths, from 12 to 125 millimeters. However, many more lengths can actually be achieved since the various segments can be screwed into one another in any combination. The system is completed by a ring which is screwed onto the spacer, or straight onto the neck if the resection is short. It has a knurled surface which rests on the bone. There are 3 diameters available, according to the width of the bone. The assembly so far described is used in epiphysis amputations. Where there is a segment of diaphysis to be resected, the PGR has a cap, slotted for extraction, screwed onto its top instead of the neck, and the spacer is located in an intermediate position on the stem, fixed also above with a special ring. The components of the PGR are arranged on 2 sterilizable aluminium trays with their profiles marked out, along with the instruments, which consist of 2 28 and 32 mm trial heads, long, medium and short, 3 rigid cylindrical reamers, 2 locking wrenches for the neck and stem, 1 impactor extractor, and 1 beater. We now see the replacement of a neoplastic epiphysis and the reprosthetization of a femur with epiphysis destroyed by cement or infection. With the femur dislocated and extra-rotated, and with a cut in at least 2 centimeters of healthy bone in secondary tumors and 3 or more in primary ones, as radicality requires, a block of epiphysis is resected perpendicularly to the diaphysis, along with the soft tissues. After accurately measuring the skeletal segment removed, the surgeon reams the diaphysis canal with rigid or flexible instruments until he reaches the necessary depth to re-establish the length of the limb. When using rigid reamers, it is better to cut mainly into the rear cortical bone, especially with highly procurved femurs and long stems, so as to avoid sticking against the front wall. In this sequence, a typical assembly using spacer is illustrated. Trying the stem in the site confirms whether the length and diameter are suitable. In connection with this, Make sure that the part to be cemented is not less than half the total length, and the diameter of the stem is the largest compatible with bone and cement. The way the ring rests on the femur is also checked. If it is not uniform, the bone must be adjusted accordingly. The femur is cemented, if possible with a plug at its bottom, and the stem is sunk as a block while held and angled correctly by the impactor. It is best if the ring rests as much as possible directly on the bone, with a minimum amount of cement in between. Mounting the head, in this case bipolar, is followed by relocating the limb. The gluteus medius and minimus tendons are fixed to the special fin, and the iliopsoas, where possible, to the tunnel. Here are the radiograms of two operations of this type, namely an osteolytic tumor of the lesser trochanter region and a pathological fracture of the neck due to an osteoproductive tumor, operated upon by Professor Carlo Motta, chief of the 1st Orthopedic Unit of the Civil Hospital of Brescia, respectively with a PGR stem and a bipolar head, and with the same in a total hip arthroplasty. Now we see a revision operation, where the residual epiphysis is practically destroyed. Here, after the loose stem has been extracted and the cement has been totally and carefully removed, in one piece or in splinters, the osteotomy takes place in solid bone. For the rest, the technique is the same as in the previous case, except that it ends by fitting a 32mm head for a cup. What is illustrated now is the use of the PGR in a case of segmentary resection of the diaphysis. Lateral incision of the thigh on the projection of the segment to be resected, with the patient lying on the healthy side. Resection of the skeletal segment and any soft parts with both the osteotomies perpendicular to the diaphysial axis. The spacer or spacers, plus the total 2 centimeters of the rings, must correspond to the length of the explant. The trial positioning also checks the way the rings rest on the bone, which if necessary is suitably smooth. Having removed the spacer, the surgeon reams both sides with rigid or flexible instruments. He then prepares the trochanteric canal through a small skin incision and through the fossa piriformis. We now see first the cementing of the distal part and then the proximal one. At this point, the stem, complete with cap, is sunk down to the upper section of the bone, while the surgeon impedes the downward outflow of cement. After the spacer is repositioned, the sinking of the stem proceeds until the required depth. Now, if the operation has gone well, only the upper edge of the cap will emerge from the trochanteric fossa. While the cement is solidifying, the spacer is held firmly compacted to both segments by the pressure exerted on the distal segment, this carefully kept in correct rotation and axis.